Thank you very much again for the very kind introduction, and thank you to Dr. Rathinasamy for making this possible and inviting me to give this talk. Like to mention, my name is Niranjan. I am a product of Salem Government Medical College, and I'm currently a cardiac intensivist at the Benderson Family Heart Center at Boston Children's Hospital in Boston, Massachusetts. And I'm a clinical instructor in pediatrics in Harvard Medical School. I've been tasked with this Himalayan task of addressing identification and emergency management of neonatal cardiac problems. This, in my very humble opinion, is a topic that should probably take about 3 to 5 hours to talk about. So I'm going to try to see if I can hit the highlights and do justice to this topic to my best ability. So I do not have any financial relationships to disclose it with my academic or research background. So just going into a brief background of why emergency management of cardiac problems in the neonatal period is important. So the congenital heart disease incidence has been reported anywhere between 8 to 12%, 8 to 12 per 1,000 live births. That comes to around 1% of every live birth, of which about 1/6 to 1/4 of these cases have critical congenital heart diseases. This is a very, very modest estimate based on the current ability to do echocardiograms or fetal echocardiograms in developed nations, but the true incidence can be much higher in a developing nation like India. Late diagnosis can lead to significant respiratory compromise and circulatory failure in about 30% of non-syndromic children with congenital heart disease. And the etiology and the way it presents can vary depending on the age at presentation and the type of congenital heart disease. I was able to pull up this article from 2018 out of AIMS, which kind of described the incidence of congenital heart disease in India from what available data there is. And as you can see, most of the population that has been reported is from the north, but there is a significant contribution from the south, notably about 38,000 infants in this particular case series that they report, or epidemiological study, I should say, of which you can see that while the incidence is about half of what you see in the north, the healthcare delivery in the south is actually very proportionate to the amount of cases that we see. We are able to deliver about 72% of care to these infants with critical congenital heart disease, and they get operated on less than 1 year of age, which is amazing in my opinion. So with that background, I was just going to quickly run through a quick presenting syndrome of common congenital heart disease and try to describe the most common ones that can be managed and what usually entails the first few steps of management as a neonatal emergency. So I think this is something that everybody will be familiar with, like predisposing factors for critical congenital heart disease. Prematurity is definitely a significant risk factor. And with the exception of pediatric arteriosis, critical congenital heart disease is about 2 to 3 times more common in infants less than 37 weeks of gestation. Family history is very important. If first-degree relatives have a higher incidence of association with congenital heart disease, and left heart obstructive lesions can carry a higher risk of recurrence. Detransposition is one of the diseases that has a very low risk of recurrence in the family. Genetic syndromes and extracardiac abnormalities, as we know, has significant association. And then maternal factors, of which gestational diabetes is very significantly associated, most likely with hypertrophic cardiomyopathy, and hypertension, obesity, phenylketonuria, thyroid disorders, and systemic connective tissue disorders are all associated. Drug exposures, including phenytoin, and more recently, there's more and more people seek fertility treatments. They've been associated with increased risk of septal defects and cyanotic congenital heart disease. In utero infections is another significant contributor. So I just don't want to dwell too much on things that we're all mostly familiar with. So I'm just going to try to go through a brief physiology of the transition from fetal circulation to neonatal heart circulation, And then from there on, we can move into the various disorders that are commonly seen and how do we approach management of those. So as we all know, the significant differences between fetal circulation and postnatal circulation in infants is going to be the mode of oxygenated blood flow. As you can see, the umbilical vein carries most of the oxygenated blood from the placenta through the ductus venosus into the IVC, which supplies the right atrium. And the pit infrarum ovale helps supply the left heart, which then circulates to the cerebral circulation. And then the PDA contributes to deoxygenated blood from the lungs because the pulmonary vascular resistance remains high during fetal circulation. So this is going to be the most critical factor that decides how various critical congenital heart diseases behave in the neonatal period, right? If the PVR remains low during the fetal circulation, at birth, the lungs expand, the PVR starts falling, and the nadir of PVR, pulmonary vascular resistance post-birth, is going to be around 48 to 72 hours after birth. And then that is when most of the diseases that are ductal dependent are going to exhibit their symptomatology, because the pressure falls across the patent ductus arteriosus and the ductus then starts closing. So postnatal circulation is significant for the the PVR falling, the shunting across the ductus falling from right to left to right. And then that stimulates the release of the ductal closing prostaglandins, and then the ductus venosus that closes with lack of blood flow from the placenta, and that's how the series circulation is then established, wherein the deoxygenated blood from the superior vena cava and the inferior vena cava is poured into the right heart, and the foramen ovale closes because of the drop in pressures across the right and left atrium. And then the deoxygenated blood is then pumped to the lungs, where the PVR has already fallen, and then the return via the pulmonary veins to the left heart, which then supplies the systolic circulation. This is the basis of the basic physiology, which drives the entire beauty of critical congenital heart disease, the entire spectrum. So the primary pathogenesis of heart disease in neonates, like I said, is based on the transition from shunt circulation to serial circulation. And any interruption in the serial circulation causes a reduced cardiac output. Aside from structural heart disease, which is the primary contributor for congenital heart disease in the neonatal period, there can also be an intrinsic interruption in myocardial function. I will not dwell too much over other causes of myocardial dysfunction today, but one significant contributor in the neonatal period is going to be arrhythmias for this population. So delving into neonatal heart disease, like I said, structural heart disease is going to be the primary contributor to the incidence. And you can easily divide it, as we've all read in all our textbooks, is into cyanotic and acyanotic heart disease. And then dysrhythmia is another common emergency presentation in the neonatal period. And then critical acquired heart diseases, which include post-viral myocarditis in enteroviral sepsis, for example, or Coxsackie sepsis, or certain types of myotubular myopathies that are common to present in the neonatal period. So the timing of clinical presentation varies with the underlying lesion and the dependence on the patent ductus arteriosus. So prior to the routine use of pulse oximetry screening, approximately 30% of the patients with critical congenital heart disease were discharged from birth undiagnosed. And they would often present in the first 2 weeks of life, or even later, depending on what the structural heart disease was. More commonly, left-sided heart lesions, such as critical coarctation or small left heart syndrome, often present in the first 2 weeks to first month of life. And the more hemodynamically less significant lesions, such as large VSDs and AV canals, tend to present in the first 2 months of life. So most commonly, the early presentation for critical congenital heart disease is going to be shock, cyanosis, and respiratory distress. Depending on what their driving pathogenesis is, They often present as with or without cyanosis, which is why their primary classification into cyanotic and acyanotic heart disease. And more often than not, if they are undiagnosed for a period of time, they often progress to heart failure, and they all kind of meld together as a common presentation of respiratory distress, similar to a lower respiratory tract infection. Ductal dependent lesions often present within the first week of life because the PDA closes generally around day 3 of life into the first week of life. And so they often present much earlier than the other non-ductal dependent lesions. Most common symptomatology for late presentation include feeding difficulties, poor weight gain, cyanosis, respiratory distress, decreased activity, irritability, and excessive sweating. So, as I said before, prior to routine pulse oximetry, 30% of these kids were not being diagnosed. So once with the advent of pulse oximetry, there has been a more of a drive to see if we can have an easy screening mechanism for critical congenital heart disease. And that's how the CCHD screen was born. So this is the standard CCHD screen that is followed by the American Academy of Pediatrics, the AHA, and the CDC. So any child in the well baby nursery greater than 24 hours of age or shortly before discharge of less than 24 hours of age will get a screen with a pulse oximeter in the right upper extremity and any of the postductal extremities, which would be left upper extremity or the lower extremities. And if the screen shows a SAT of less than 90%, we will repeat the screen in an hour. And if it's less than 90%, it will be repeated again. And if there are 3 failed screens or 3 screens with SATs less than 90%, it would be considered a failed screen. If the SATs are between 90 to 95% in the right hand and the foot is less or more than 3 points lower, then it is considered a failed screen. So there's a huge pitfall for this, that it does not screen for all congenital heart diseases, and it does not account for other anatomical nuances that can cause a differential saturation or equal saturation in the presence of critical structural heart disease. One such example is going to be your DTGA, your dextrotransposition of great arteries, where you can have reverse differential cyanosis, in which case your right upper extremity is going to have high or lower saturations than your postductal saturations because of streaming of blood across your atrial septum. So to account for that is why we started doing the hyperoxia test. The essential thought process behind the hyperoxia test is going to be that the patient has a blood gas that is measured from the right upper extremity on room air or an FiO2 of 21%. And second blood gas is measured after exposure to 100% oxygen. And the response is then noted and the disease classification is sought after that. And I mentioned this is because this is a very simple and effective test in the absence of a facility to do an echocardiogram within the first few days of life. And that can often screen in or out some of the major congenital heart diseases. So if the patient has a normal response, their PaO2 or partial pressure of oxygen in their arterial side is going to go from about 70 to 100 to greater than 300. If they have a lung disease of of prematurity or some form of neurological disease, they're going to have a modest increment in their partial pressure of oxygen. If they have methylhemoglobinuria, they're going to measure with low saturations on the pulse oximeter, but their PaO2s are going to be still showing a robust response. It's because they of increased affinity of the hemoglobin molecules to the oxygen. And then in cardiac disease, the major differences that you can delineate from this study is that if it is a parallel circulation, like your detransposition of great arteries, you're not going to see a significant response to administration of oxygen, right? Because all your hyperoxygenated blood is still going to circulate through your right heart back into your lungs, and they're not going to go into your systemic circulation and therefore will not reach the arterial side. If there is proper mixing in the heart with reduced pulmonary blood flow, it's going to be similar to your DTGA kind of circulation. If there is mixing without a restricted pulmonary blood flow, there's still going to be a modest response, right? So this is how you differentiate a patient with DTGA, for example, from other critical congenital heart disease in this situation. So we can kind of account for like reverse differential cyanosis, like I mentioned in the previous slide. So this is like the most common critical congenital heart disease that you can kind of differentiate between cyanotic and acyanotic, and whether they need their patent ductus arteriosus or not. So I'm going to quickly go through these different disorders, and then we'll kind of go through each one of those in a very brief detail. So the ones in the orange are all left-sided structural heart disease. One on the right are right-sided obstructive lesions, and more often than not, the left-sided lesions are less likely to be cyanotic as opposed to the right-sided lesions. And then the green ones are the parallel circulations, and then the miscellaneous ones are in yellow here. So the most common left-sided critical heart diseases, critical congenital heart diseases that you're going to see in the neonatal period is going to be aortic stenosis, which can be critical or moderate to severe, depending upon the pressure gradient across the aortic valve. And the critical AS kids generally have differential cyanosis between their upper and lower extremities, right? Pre and post ductal, because they don't have anterograde flow across the aortic valve. And so they have retrograde filling of the arch from the PDA, which is coming from their deoxygenated pulmonary blood flow. So they often have differential cyanosis for that reason. And critical cohort often has differential cyanosis as well because of their reduced blood flow at the lower extremity. And more often than not can be identified by blood pressure difference between their right upper extremity and the rest of the extremities. And then interrupted aortic arch is another instance where they can have a ductal dependent circulation. So if you notice, most of the critical left-sided heart diseases are all ductal dependent lesions. So critical AS, critical cohort, and interrupted arch are all need their patent ductus arteriosus in order for them to have appropriate cardiac output. Tetralogy fellow, as we all know, is pretty common and has variable cyanosis depending upon what their flow across the right ventricular outflow tract is. And that's what manifests as TET spells. And they can be ductal dependent if they have significant amount of pulmonary stenosis. Tetralogy fellow with pulmonary atresia is definitely a ductal dependent lesion because there is not enough pulmonary blood flow due to the atresia of the pulmonary valve. Pulmonary atresia with intact ventricular septum is one of the other critical congenital heart disease that has very poor pulmonary blood flow. I'm sorry, did someone have a question? All right. So PAIVS, or pulmonary atresia with intact ventricular septum, is another ductal dependent lesion because they don't have enough pulmonary blood flow. And then critical PS is very similar to critical AS with cyanosis, as is tricuspid atresia or severe Epstein anomaly. TGA, as I mentioned before, is a parallel circulation. So there is no oxygenated blood that is reaching the systemic circulation. With appropriate mixing is how they maintain their cardiac output. So they often have cyanosis, and they are definitely ductal dependent for their systemic circulation. And then total anomalous pulmonary venous connection is an entity of its own, which we'll go a little bit further in a minute. So I'm just going to go forward. So before we go on to the individual lesions, for which I have some videos that kind of describe their circulation, I'm going to just quickly go over physical examination. So more commonly, the first things we try to note for in physical examination is whether or not this baby is in shock. So that's going to be a first indication of how quickly you need to act on this baby, whether this baby has a significant obstructive lesion, and what is the next best step. So cap refill and your four extremity blood pressures is going to be one of the first vital signs that you need. And thereon you can start looking at, auscultation, whether there's a split S2, abnormal heart rate, and what is the precordial impulse. With the precordial impulse, you can identify if there is dextrocardia, which is common with like TAPVR or double outlet right ventricle and other right-sided lesions with heterotaxy. And If is there an abnormal S2 splitting, which can be common in other right-sided lesions, and other extra heart sounds like pathological murmurs. Is there hepatomegaly, which could indicate significant amount of right-sided obstructive lesion? Or is there diminished pulses in the lower extremities, which is common with left-sided obstructive lesions? So I'm going to spend some time over management. I hope I have some time. I'm going to spend at least next 5 minutes on management. So these mainstays of management are going to be management of their physiology, essentially. So we have to identify where is the level of obstruction or mixing. What can we do to help that? So of which there are two major things, oxygen and prostaglandins. That's going to be useful in these situations. The oxygen is a double-edged sword because it can help or harm depending upon your lesion. And prostaglandins is another another agent that can help or harm, and I'll explain why in a second. There are certain other things that you can do routinely for shock, like administration of fluid, low-dose inotropes. And then morphine is helpful, especially in TED spells, as we know, along with oxygen. And for non-structural lesions, managing the primary arrhythmia is helpful. And in most cases, in the baby's 2-3 days of life, managing their pulmonary vascular resistance is going to be crucial in maintaining their balanced circulation. And when we've kind of stabilized them and gotten them out of cardiogenic shock, the next best thing is going to be catheter-based interventions, depending on if it is, for example, if it is critical aortic stenosis, doing a balloon valvuloplasty for the valve, or surgical interventions, depending on what their primary structural heart disease is. Full disclosure, I'm not going to spend a lot of time on catheter-based or surgical-based interventions because that is not my area of expertise and that is not within the scope of today's conversation. So quickly going towards just trying to explain whether oxygen and prostaglandins are helpful, focusing on the left-sided heart lesions. Most of the left-sided heart lesions, oxygen is going to be actually more harmful than helpful because with an open patent ductus arteriosus, you're going to have increased flow across the ductus towards the pulmonary circulation, thereby stealing blood from your systemic circulation. So like I said before, PVR is going to be the biggest modifiable thing in the first week of life. So when these patients present in the first 24 hours of life, they often have high pulmonary vascular resistance, and they're going thereby have right to left shunting across the PDA and thereby maintain their systemic circulation. But if they have a critical coarct, for example, and your PVR is high and promoting your systemic output, if you give them 100% oxygen, the PVR is going to fall and all the blood's going to shunt across the PDA to their lungs, and they're going to have a significant fall in their systemic output. That being said, the PDA is the only thing that's going to keep most of these kids alive. And so they often are responsive to prostaglandins. And I would not hesitate to put these kids on prostaglandins if your suspicion is a left-sided obstructive lesion. So I have some, I don't know if this plays. Yeah, that plays. So I'm just going to go through like quickly a few lesions with these graphics. So just to highlight, so this is an aortic stenosis. As you can see, there is no mixing in these lesions. Blue blood is blue to the right heart, and the red blood is red. So this is one of the lesions that if you relieve the obstruction, these kids do very well in the first month of life. Coarctation, as you can see, there is usually in the juxtaductal region. When the ductal tissue starts narrowing is when you have the isthmus narrowing and cause critical coarctation. So opening up the PDA often helps in these lesions by giving some flow across the PDA to the systemic circulation. And this is when if you drop the PVR too acutely, you will have a steal from your systemic circulation because all your anterograde flow across the aortic valve is going to get stolen into your pulmonary circulation and go into your lungs instead of the rest of the body. So right-sided obstructive lesions, tetralogy fellow, as we all know, oxygen is very helpful. And if they have significant right ventricular outflow tract obstruction, prostaglandins can be helpful to maintain pulmonary blood flow. Tetralogy fellow with pulmonary atresia, often prostaglandins is helpful. And oxygen is helpful in most of these lesions. Pulmonary atresia with intact ventricular septum, critical PAs all behave very similarly and do help with prostaglandins. Tricuspid atresia is a little bit different. Oxygen is usually often helpful, but if there is not a lot of anterograde blood flow across the right ventricular outflow, then prostaglandins are usually helpful to drive some pulmonary blood flow. In severe neonatal Epstein anomaly, depending on how the tricuspid valve function is, also prostaglandins might be helpful if there is severe TR. So just going through their circulations real quick. So this is your tetralogy fellow. There's a large VSD with conal septal deviation. So there is some obstruction to your pulmonary blood flow. So your oxygenated blood has some trouble getting to your lungs. But the VSD helps offset that a little bit. And that's why increasing your SVR fills up your left ventricle as well as increases your preload. So Nietzsche's position, as we all know, giving some morphine and giving oxygen all helps improve the pulmonary blood flow and thereby reducing the amount of hypoxemia. And that's why it is helpful in that spell. Pulmonary atresia, like I said, can be with or without an intact ventricular septum. This graphic demonstrates when there is VSD in addition to pulmonary outflow obstruction. So more often than not, they have mixing of blood, and these kids actually do a little bit better because they have an alternate source of pressure release. Like the RV is not super pressurized, but with an intact ventricular septum, often they struggle a bit more and often are dependent on prostaglandins for their pulmonary blood flow. Tricuspid atresia is a little bit more complex. It can be type 1 or type 2, depending on whether the great vessels are related appropriately. So essentially type 1 is the ones where the aorta is arising from the left ventricle, the pulmonary artery is arising from the right ventricle. But A, B, and C is depending on how much pulmonary stenosis that they have. Like, as you can see, there's complete pulmonary atresia in type A, and type B is like some amount of pulmonary atresia with a small VSD, and type C is large VSD with no pulmonary atresia. And type 2 is basically a TGA on top of tricuspid atresia. And then Epstein anomaly is basically the tricuspid valve is pushed downwards. So there is atrialization of the ventricle, and one of the leaflets are usually stuck, which means there is a lot of DR, and therefore there is no anterograde blood flow across the pulmonary circulation. So then transmission of great arteries, again, this is another situation where both oxygen and glandins are helpful. As you can see, all the deoxygenated blood enters the right ventricle and enters the systemic circulation, whereas all the oxygenated blood enters the left ventricle and then enters the pulmonary circulation. So the lung is oxygenating well, the heart is pumping well, but there is no appropriate CV circulation. So often they are dependent on their patent ductus arteriosus. These patients often are dependent on their shunting to be appropriate, and they can be deoxygenated if their PVR is high in the first few days of life, and that's why oxygen is helpful in this situation. The reverse differential cyanosis piece usually occurs from shunting across the atrial septum and then directly into the systemic circulation. All these kids are also dependent on a patent atrial septal defect or the patent foramen ovale for adequate systemic output. And these are the kids that sometimes, if they have a whiteout lung right after birth, need to go to the cath lab to balloon dilate their atrial septum in order to maintain adequate systemic output and relieve the atrial pressure. And then finally, the large VSTs and AV canals are kind of kids that can be really innocuous and present at 3 to 4 months of life. But in the neonatal period, more often than not, they behave appropriately and they're not ductal dependent, but that is why. And more often than not, these cases, oxygen can be more harmful because they increase the amount of pulmonary blood flow and pulmonary output, and their lungs can get quite wet. And that's why they start breathing faster and they have significant respiratory distress. This is a graphic with truncus arteriosis. As you can see, all the blood is mixed because of a free-flowing ventricular septal defect with a common truncal valve that supplies both systemic and pulmonary blood flow. Total anomalous pulmonary venous connection is a very complex entity of its own, but I'm just trying to illustrate the infradiaphragmatic versus supradiaphragmatic TAPVC. As you can see, the anomalous venous return comes into the IVC here and then to the right atrium. These ones are more commonly obstructed, and unless they can go on ECMO or get repaired within the first day or two of life, these kids often die. Because of their inability to relieve the obstruction. They have high pulmonary venous pressures and high pulmonary pressures and high left atrial pressures and complete whiteout of their lungs with hypoxemia. Supradiaphragmatic version is a little bit more innocuous. They often drain into the innominate vein and then to the right atrium. These ones can be repaired in the first week of life, but they're also pretty sick at birth. So very briefly, non-structural heart disease. I think I may be over time. I apologize for that. Non-structural congenital heart disease. Long QT syndrome very rarely presents in the neonatal period. They often present in adolescents. SVTs and ectopic atrial tachycardias are pretty common in neonatal period, especially if there's a strong family history. Congenital myopathies are other ones that may be mitochondrial origin, or there are some myotubular or myofibrillar myopathies that are present with profound cardiac dysfunction and often just need pressor support until we figure out what's the next best step for their management. A brief word on prostaglandins. The initial dose depends on the clinical setting. If you can hear a very good murmur in the infant, they can often start on a very low dose of 0.1 mics per kilo per minute. If there is a concern that the patient is more than a week old or a few days old, you cannot appreciate a protectus murmur. They often need to get started on 0.05 mics per kilo per minute. The question is, if they present at 2 weeks of life, is it worth doing prostaglandins? If you're suspecting a critical coarct or obstructive left-sided lesion, you can't go wrong by starting prostaglandins. Even sometimes we use doses of 0.1 mics per kilo per minute. The biggest thing that we worry about in these kids with higher doses of prostaglandins is apnea and hypotension. So you should be prepared to intubate the patient and provide mechanical ventilation, which would be needed for other reasons outside of just the apnea, because most of these critical aortic stenosis or critical coarcts who present at the second week of life are often in florid shock, and they need to get intubated for that reasons as well. And then hypotension and tachycardia is pretty profound because prostaglandin, as we all know, is a vasodilator, and it can cause significant hypotension.